Now, let's talk about a new topic, that is aplastic anemia. It's an important part of hematological discussion. But before we go into the topic proper, you should know about pancytopenia, which is the definition or meaning. Pancytopenia means reduction below the normal values of all three blood lineages. All three. That means leukocyte, platelet, and erythrocyte. Means RBC is decreased, platelet is decreased, and WBC, especially the neutropenia, occurs. Pancytopenia requires the microscopic examination of a bone marrow biopsy and marrow aspiration to assess the overall cellularity and morphology. That means, what is the cause of this pancytopenia? One of the most important tests is bone marrow aspiration or biopsy. Now, you should know the difference between aspiration and biopsy here. Aspiration is done only when there is a cellular bone marrow, or it is successful when bone marrow is still cellular, whereas when bone marrow is dry, like it is replaced by fatty tissue or some fibrous tissue, aspiration fails, then we need to go for bone marrow biopsy. So aspiration is done with the help of bone marrow needle, whereas bone marrow biopsy should use a cutting type of needle. Let's move on. Now, what is aplastic anemia then? It's a syndrome of marrow failure associated with pancytopenia, that is anemia, neutropenia, and thrombocytopenia. Remember, the total leukopenia doesn't occur in aplastic anemia because it is a disorder of myeloid lineage or myeloid series. The lymphoid series is not affected in aplastic anemia. Now, let's go back to the basic thing here. From the myeloid lineage, all types of cells apart from lymphocytes and natural killer cells are developed. That means RBC, platelet, and whole granulocyte series, even the macrophages. That's why anemia, neutropenia, and thrombocytopenia occurs predominantly here. The marrow failure results from suppression or disappearance of the multipotent myeloid stem cell, which is clearly written here. They are developing in the bone marrow when the environmental insult or some genetic alteration changes these myeloid stem cells in the bone marrow, then aplastic anemia occurs. Aplastic anemia is also known as hypoplastic anemia in different textbook. Aplastic means total loss of the cell, total aplasia of the bone marrow, whereas hypoplastic is the better term actually because some function of the bone marrow still exists. Now, another important part of today's lecture is what are the causes or etiology of aplastic anemia. We roughly divide them into two groups, acquired and congenital. Acquired or congenital or inherited. Now, acquired causes may be idiopathic, they are the most common one. We do not know the pathogenesis or the cause, but we presume or we hypothesize that primary stem cell defect or immune mediated causes are responsible for the majority of aplastic anemia. Regarding the chemical agents, they are dose related damage or idiosyncratic damage. Now, dose related depends on it is directly proportional to the dose what the patient takes. Higher the dose, severe the damage. Whereas idiosyncratic doesn't depend on the dose. Even if one dose or one drop of whatever form of the medicine patient is taking, that can result in idiosyncratic reaction, and that can damage the bone marrow. So these drugs are alkylating agents like cyclophosphamide, antimetabolites like methotrexate, benzene is a chemical compound, and chloramphenicol is a broad spectrum antibiotic. Okay, so that's why chloramphenicol is not usually given to our patient these days because of this dreadful adverse effect. Whereas idiosyncratic reaction again can be caused by chloramphenicol, streptomycin, chlorpromazine, and insecticide like DDT and parathion or malathion. That's why farmers are quite commonly affected from aplastic anemia because of prolonged exposure to insecticide. So good history has to be taken. Let's move on. What are the other factors? Regarding the physical agents, irradiation or radiation exposure is one of the big factor here. Especially whole body irradiation play a big role. apart from damaging different organs or tissues, okay, bone marrow is also severely damaged by radiation exposure. Think about some person who is working in the X-ray department or CT scan, the radiology department of the hospital, or some accidental exposure to the radiation, like the nuclear substance leakage or something like that. Another is viral infection. The important viruses are hepatitis B, an unknown virus causing hepatitis, cytomegalovirus, Epstein-Barr virus, and varicella zoster. Any of them may suppress the bone marrow, but hepatitis B is quite commonly asked in the exam. Now, the second group is the inherited disorder. Okay, and the important ones are Fanconi anemia, dyskeratosis congenita, and amegakaryocytic thrombocytopenia. Fanconi anemia is also known as congenital aplastic anemia. And in this condition, the child is usually affected. Okay, the child is quite short in stature or height. There is some other bony defects as well as black pigmentation on the skin. And when we check the bone marrow, there will be hypoplastic bone marrow, and peripheral smear shows pancytopenia. So this is about Fanconi anemia. Dyskeratosis congenita is the mainly a disorder of the skin, okay, skin and skin appendages along with the bone marrow suppression. And amegakaryocytic thrombocytopenia means there is the mother cell, the parent cell of the platelet is megakaryocyte. They are not properly found or properly formed in the bone marrow. Now, another part of this lecture is pathology of aplastic anemia. What is really happening inside the bone marrow or in the peripheral, smear. The hallmark of aplastic anemia is peripheral pancytopenia coupled with hypoplastic or aplastic bone marrow. This is very clear. Okay, the concept should be there. The severity of the clinical course is related to the degree of myelosuppression. Severe degree of myelosuppression, more severe clinical course. Minor degree of myelosuppression, less severe clinical course. And that is explained very well by this, example. Now see here. Severe aplastic anemia is defined as a condition in which two or more cell components have become seriously compromised. Out of the three, the two components, if they are severely compromised like this, then it is known as severe aplastic anemia, and the prognosis of this patient, okay, is very poor. That means there is high chance of death within next 6 months. Now, what are those components? Absolute neutrophil count, or ANC, is less than 500, platelet count less than 20,000, and reticulocyte count less than 1% in a patient whose bone marrow biopsy material is moderately or severely hypocellular. Now, this is known as severe aplastic anemia. So both components are there. Pancytopenia in the peripheral smear, as well as bone marrow biopsy shows hypocellular bone marrow. Now, let me explain what do we mean by absolute neutrophil count. Every student should know what is this. So let's take one example here. If the total leukocyte count of the patient, okay, TLC is 2000, and if the differential leukocyte count regarding neutrophil percentage is 10. Now, what is the absolute neutrophil count? You just take the percentage. So 10% out of 200 is 200. So A and C is 200. I'm sure like this you can easily calculate. So in the exam, this may be asked as one of the important questions. If A and C is less than 500, the criteria for severe aplastic anemia is already met. So this is the point. Let's move on. Now, another part is pathophysiology. What is really happening inside the bone marrow? How bone marrow is getting suppressed? What is the mechanism? The bone marrow failure may be a consequence of a direct cytotoxic effect on the hematopoietic stem cell from a drug or a chemical, like alkylating agent, like benzene, like chloramphenicol, okay, like streptomycin, or it may result from either cell-mediated or antibody-dependent cytotoxicity. Cell-mediated means type 4 hypersensitivity reaction, or antibody-dependent cytotoxicity is type 2. So both of them may be involved there. There is a very strong evidence that many cases of idiopathic aplastic anemia are caused by an immune-mediated process with increasing circulating T lymphocyte producing cytokine that suppress the hematopoiesis. So this is a strong belief we have because it is supported by the treatment part as well. Anti-thymocyte globulins are used very commonly for the treatment. That means there has to be, over uh, activity of our immune system, and that needs to be suppressed by this medicine. Another is early apoptosis of hematopoietic progenitor cell. That means the myeloid stem cell. Okay, they are dying very early. This is a programmed genetic type of death, and it may play a role in pathogenesis of this disease. Different, environmental insult, and we have talked about that in the last class. Like viruses, important is hepatitis B virus. Okay, even cytomegalovirus, even varicella zoster virus, or drugs like chloramphenicol, okay, like alkylating agent, like a chemical like benzene. So all of these, okay, cause damage of the stem cells of bone marrow, and what they do, they will alter the stem cells genetically. That is called mutation. After doing that, okay, these mutated cell, they will express new antigen on the surface. Means they are a changed cell now. These new antigens are, identified by T cell, and T cell will produce certain cytokine. Like two cytokines are written here. Okay, so you don't need to remember in detail. At the same time, these genetically altered stem cells, cannot multiply or differentiate into mature cells. That results in marrow aplasia or hypoplasia. So this is the basic mechanism. Now, one point I like to highlight here: if we, do some investigation, we can see increased number of T cells circulating in the system. That means this immune mediated mechanism play a big role in the causation of aplastic anemia. That's why for the treatment, we can use anti-thymocyte globulin as one of the, major drug. Let's move on. Now, let's talk about clinical features of aplastic anemia, very important part of this lecture. See this. Now, everybody already understand the meaning of aplastic anemia. All three cell line will go down. So as a result of that, anemia occurs. Because of decreased RBC, because of decreased hemoglobin, anemia will happen. So this anemia is insidious in onset, not a rapid onset. It is progressive, and it is persistent with fatigue, and even there may be cardiac failure in the patient. Because RBC is not getting synthesized, or getting synthesized in a very low amount. In case of hypoplastic anemia, it is still synthesized, but it is decreased in number. But in aplastic anemia, it may not be synthesized at all. So think about how severe anemia would be here, and all the features of anemia would be present. The second is bleeding manifestation because of decreased platelet. So petechiae, purpura, bleeding from the mucosa, even hematuria, and GI bleeding like hematomesis and melena can be there. I'm sure students know the meaning of this. Petechiae is a pinpoint size bleeding, pinpoint size. The smallest, type of bleeding is called petechiae. Purpura, slightly bigger than that. Ecchymosis also can be added here, which are known as blue patches. Mucosal bleeding. A good example I can provide here is epistaxis. What is epistaxis? Yes, what is that?
Bleeding from the nose.
Bleeding through nose.
Exactly, bleeding, okay, from the nose. Then we can write gum bleeding here. Gum bleeding is also quite common in case of aplastic anemia. Just like that, any mucosa can develop hemorrhage or bleeding. Hematuria is blood present in the urine, and GI bleeding, okay, it may manifest as a hematomesis and melena, or even hematochezia. These are the three terms. So see here, So let me write that for you so that you know it. Though many of the students already know, I'm 100% sure about it. Hematomesis, melena, and hematochagia. Now, what is hematochagia? Anyone? What is that? Who can answer this? Hematochagia. What do you mean by that?
Sir, it is a vomit. Sir, it is like the passage of fresh blood from the anus side, sir.
Yes, absolutely. You're right. Now, let me explain this. Maybe you have done this, a little while earlier, like in pathology, so maybe forgotten. Hematomesis is vomiting of blood. Vomiting of blood. That is hematomesis. So, if upper GI hemorrhage occurs, then there is a high chance of hematomesis. Sometimes the bleeding is fresh. Sometimes it is altered. Sometimes it is altered. We call that acid hematine. Melena is a passage of dark and tarry stool, very foul smelling stool. That is melena. Again, melena occurs when there is upper GI bleeding. Hematochagia occur in case of lower GI bleeding. Okay, lower GI, the blood is not altered, so it is a relatively fresh type of blood. So in one sentence, we can wrap this up. Hematomesis and melena are the feature of upper GI bleeding, whereas hematochagia is the feature of lower GI bleeding. That is a big topic in pediatrics in 6th semester. Okay. Now, what happens because of decreased WBC? Now, the patient suffers from different infections. That infection can be serious bacterial infection and invasive mycosis. This is a fungal infection, invasive type of fungal infection or systemic fungal infection, you can say. That's why the patient, has high chance of death because of this infection. Some hospital-acquired infections are quite common, like, MRSA strain of Staphylococcus aureus, maybe Pseudomonas aeruginosa, maybe Klebsiella pneumoniae, maybe Proteus mirabilis. So many different organisms can cause infection because of immunocompromised situation. And why immunocompromised situation? Because of pancytopenia. WBCs are very decreased, especially the neutrophils. One of the very important point here, there is no hepatosplenomegaly in this case. And that is the big factor which separate between leukemia and aplastic anemia. In leukemia, because of the infiltration of liver and spleen, as well as lymph node, there is lymphadenopathy and hepatosplenomegaly. Whereas in aplastic anemia, they are absent. Okay, and the reason behind it is because those stem cells which are originated from the bone marrow, they themselves are absent here. Okay, so they cannot be formed in other organ as well. Let's move on. Now, after talking about these clinical features, how we diagnose aplastic anemia? What are the important investigation we like to do? Now, we always start with CBC, and CBC will show us pancytopenia. Now, see this, anemia, leukopenia, or neutropenia, you can write, and thrombocytopenia. So these are classical features. Sometimes only 2 cell line will go down, not all 3. And that is also suggestive of, pancytopenia. 2 cell line out of 3. Because 1 cell line may be taking time to decrease, So it depends on the timing of your investigation. So please take it like that. Another is a peripheral smear exam. So what is the size of RBC? What is the appearance of RBC? What is the size and appearance of leukocyte or WBC? And what is the size or appearance of platelet? So these all are very, very important, finding here. Reticulocytopenia. The reticulocytes are also one of the cells in RBC series. So definitely, if I measure the reticulocyte percentage, it will go down. And normally it is around 2%. Okay, so in this case, it is even less than 1%. Now, bone marrow examination will give you the diagnosis. And bone marrow examination can be done by 2 steps, aspiration or biopsy. Now, in this case, aspiration is not a good idea because the bone marrow is already fibrous. There is not much bone marrow left inside. So while you aspirate, nothing may come out. So the better option would be biopsy. Now the difference between aspiration and biopsy is, in aspiration, we'll put a bone marrow needle, okay, into the medullary cavity, and we aspirate the bone marrow. Bone marrow is like a thick blood. Remember this, thick type of blood. It has a lot of cells. Whereas biopsy is a piece of tissue. We cut through the cutting needle, a chunk of tissue is taken and sent to the lab. So this is biopsy. Now, another important investigation here to rule out the congenital aplastic anemia is chromosomal breakage analysis. Now, can anybody tell me what are the example of congenital aplastic anemia? Yes. Which are those names? We discussed this in the last class. Anyone? They are Fanconi anemia. Fanconi anemia, okay. Then dyskeratosis congenita and amegakaryocytic thrombocytopenia. Now, among them, Fanconi anemia is the most common one. And in case of Fanconi anemia, the chromosomes are very unstable. If we can detect this instability of chromosome, then probably we can think of, oh, this is a case of Fanconi anemia. At the same time, there may be some congenital anomaly present in the child. Now, what is this bone marrow biopsy all about? Now, how to do bone marrow biopsy? Can you tell me which is the site for bone marrow aspiration or biopsy? From where we take that? Anyone?
From
backbone, lumbar area,
vertebrae.
Okay. Now this was not taught to you before, so listen properly here. Now there are different sites for the bone marrow biopsy. We can take bone marrow biopsy from the sternum also. We can take the bone marrow biopsy from other bone, but clinically one of the important area is posterior superior iliac spine or posterior inferior iliac spine. That area means you trace the iliac crest and go on the back side, and there you can easily feel posterior superior iliac spine. So that near about that is the area where we put our needle, or cutting needle or aspirating needle. So this is how bone marrow biopsy or aspiration is done. This is the invasive procedure, so definitely it is a painful one. It is a painful for the child, for the adult as well. So a lot of local anesthetic has to be given. Then you put or drill that bone with the bone marrow needle. So in aplastic anemia, now let's go to the interpretation here. In aplastic anemia, the specimen of the bone marrow are hypocellular. This is a very important point. Just like this, it is seen like this. Not much cells. They are replaced by either fatty tissue or fibrous tissue. The specimen is considered hypocellular if it is less than 30% cellular in individual younger than 60, or if it is less than 20% cellular in those people who are older than 60. So this type of report is given by pathology lab to you. Okay, you don't need to see the bone marrow on your own. You just need to interpret it. If this type of report comes, then you are almost certain, yes, this is a case of aplastic or hypoplastic anemia. Now, another point, if these cells are decreased, then what replaces them? So I already talked about, there is fatty cells or even fibrous tissue. Now, the final part is the treatment. Now, let me, tell some important points in the beginning. This is a disease which is very difficult to manage. Very difficult. Why is the question? Because look at the patient. What are the clinical features here? Severe anemia, severe infection, and manifestations of bleeding. Now, what will happen? I need to give some supportive treatment, but they do not cure the patient. These are not curative treatment. I need to give blood transfusion, I need to give platelet transfusion, or I need to give some colony stimulating factors for the synthesis or growth of WBC. I need to give very powerful antibiotics, broad spectrum antibiotics to control the infection, but they are not curative treatment. And after some time, patient again will develop those features. So the definitive treatment has to be done sometime in the life. That is done by bone marrow transplantation and immunotherapy. So we divide the treatment into two parts, supportive and definitive. Supportive treatment is the symptomatic treatment. According to the situation, we go for it. And definitive is the curative one. The most important here is bone marrow transplantation. If that option is not available, then we can go for immunotherapy. That is done by anti-thymocyte globulin. Now let's elaborate on this. Now, bone marrow transplantation. Let's talk a little bit about it. For patient with a human leukocyte antigen identical sibling marrow donor, allogenic bone marrow transplantation offers a 90% chance of long-term survival. So this is an excellent number, excellent percentage. But the condition we should have is there should be a donor, and the best donor is sibling. Okay, this sibling, and the sibling should have matched HLA antigen with the patient. That is the best donor. The risk associated with this approach include the immediate complication of transplantation. Okay, the immediate complication of transplantation. Sometimes there is hyperacute rejection, especially if HLA is not typed. Still, you go for the transplantation. So the bone marrow is rejected quickly. Another one, there will be a lot of complications of the procedure itself. For example, what should we do before bone marrow transplantation? We should kill all the bone marrow cells of the patient first by giving either irradiation or very powerful, alkylating drug like cyclophosphamide. Now the patient will be totally immunocompromised. Any type of infection can occur in that individual. Okay, and that's when there is a role of very powerful broad spectrum antibiotic. Now one small question for you. Okay, if you want to cover the gram positive organism like staphylococcus aureus or other gram positive cocci or those type, which antibiotic you give? Which antibiotic?
Cyclosporin.
Like,
Cyclosporin, sir.
No. You are not getting my question. Cyclosporin is the immunosuppressive drug. But my point is to cover those organisms, okay, to cover those bacterial infection, which is the highest ranking, antibiotic for the gram-positive organism, which is that? For the
Penicillin, sir.
Beta-lactam penicillin.
Cephalosporin.
Cephalosporin, beta-lactam penicillin.
Good, okay. But you have started from the low rank antibiotic, but the answer I can accept here. This is the way student should answer. But exactly, listen, this is a very serious condition. This person is totally immunocompromised, so we don't want to take any chances with low rank antibiotic here. I can give penicillin, but penicillin may not cover MRSA strain of Staph aureus. So which antibiotic covers that? Which is the antibiotic I'm talking?
Erythromycin, sir.
Vancomycin.
It is vancomycin, okay? Never forget it. Vancomycin is the one which should be given to cover MRSA, that is methicillin-resistant Staphylococcus aureus. Some higher, rank antibiotics are also there, like linezolid, okay, dactinomycin. These are also there. But till today, vancomycin is a very good antibiotic for gram-positive cocci coverage. Whereas for the gram-negative, we can start with third generation cephalosporin. If that do not work, we can go for fourth generation cephalosporin like cefepime. Okay, and then even the higher rank gram-negative antibiotics are available these days, like meropenem or carbapenem. Meropenem or carbapenem, they're excellent drug. Now, let's wrap this up. So what should we do? I will start vancomycin from one side, and I'll start meropenem or carbapenem from the other side. If I believe fungal infection is there, I can go with amphotericin B. So these are very powerful antibacterial and antifungal drug. And these are necessary in this case because the patient is immunocompromised. Now see this. Let's talk about something else. The graft which you have done may fail later on. Chronic rejection can occur, and there is one condition known as graft versus host disease. I'm not sure whether you have studied this in immunology or not. The meaning of this is there are certain lymphocytes which are present in the graft. Graft means the bone marrow which we have taken from the donor. That is called graft. So there may be some donor lymphocyte which are still present there. Those donor lymphocytes, while entering into the patient's body, they can damage patient's tissue. This is known as graft versus host disease. And there are different types of manifestation now. Okay, skin may be affected, subcutaneous tissue may be affected, GI tract may be affected because of graft versus host disease. So these are some of the important problem of bone marrow transplantation. Let's talk further about bone marrow transplantation here. Yes.
Sir, after if we transplant the bone marrow of a sibling's donor, and then if HLA typing and everything is like according to the donor and recipient, then we still have to give the immunosuppressant for rejection, or we don't need to do anything.
We have to give. Okay, we have to give. There's no doubt. Still, the matching is there, but still that is not the self antigen, isn't it? That is not the self antigen. Okay, it is the antigen which belongs to another person. So we still need to give this immunosuppressive therapy. Now we will come to that. Okay, let me go through this slide first. Now, what are the late adverse effect? Now see this. The late adverse effect of bone marrow transplantation, they are associated with the transplantation like secondary cancers, cataract, short stature, hypothyroidism, and gonadal dysfunction. Now, the answer which he is seeking will come here. Now, what we do after bone marrow transplantation, just to avoid the rejection later on, we have to give prolonged immunosuppressive therapy like cyclosporine. Okay, and these drug have a lot of side effect. Sometimes what we do, we give radiation therapy to kill those cancers, to those bone marrow cells before. So because of that radiation exposure or therapy itself, a lot of adverse effect may develop, and these are secondary cancer. Okay, later on, when the child survived this aplastic anemia, after many years, cancer may occur, and the common cancer is lymphoma or leukemia again. Cataract means, what is cataract? Yes?
The cataract is the opacification of the lens of the eye.
Very good.
Yes, sir.
Exactly. I'm sure many other students also know it. Cataract means, the lens is not, clear. Lens is not clear. It is not transparent anymore. Okay? There is a white opacification of the lens. Short stature. This is because of damage of the pituitary gland. And if pituitary gland is damaged, there is no release of growth hormone. So the child will become short. Hypothyroidism because of damage of thyroid gland. And gonadal dysfunction because of damage of the gonad, or even because of damage of pituitary gland. You can give that type of explanation. So this procedure, okay, has a lot of problem. Because of this, and because of a very expensive type of treatment, many people opt against bone marrow transplantation, even if we counsel them properly. Now, by including anti-thymocyte globulin (ATG) and cyclophosphamide into the transplant conditioning regime, the chance of transplant rejection is decreased. The conditioning means before you go for bone marrow transplant, okay? This is the meaning. Only 1 of 5 patients has a human leukocyte antigen matched sibling donor. So allogenic bone marrow transplantation is not an option for the majority of the patient. See this, only 1 of 5 patients has a human leukocyte antigen matched sibling donor. That is 20%. So in different textbook, it is written only 20 to 30% of the cases can get bone marrow from the sibling. Because if it doesn't match, we cannot give. There will be instant rejection. So this is a big problem in case of bone marrow transplantation. That is to find the donor. Now, if bone marrow transplantation is not the option, then what is the next option we have? Okay, that is immunotherapy. We still have another type of treatment which is available. That is immunotherapy, and this is done by ATG, antithymocyte globulin, and it may be combined with cyclosporine here. Look at the response rate, around 60 to 80. Bone marrow transplantation has 90% survival or cure rate, whereas ATG has 60 to 80%. So it's still good. Okay, so it is a good alternative. As many as 25 to 30% of the responders, they relapse after discontinuation of immunosuppressive therapy. And some patient must continue cyclosporine for several years to maintain a hematological response. So this is an important point. So some unfortunate patient may relapse after we stop this immunosuppressive therapy, and some other patient, we have to continue the cyclosporine for many years. And the cyclosporine itself is a toxic substance, a toxic drug. This is an immunosuppressive drug. So later on, a lot of side effect may happen because of this drug itself. Another important point you need to know here, we need to stimulate that bone marrow by giving stimulating factor. And these are called granulocyte colony stimulating factor or granulocyte macrophage colony stimulating factor. They can help the process, especially they can stimulate the young neutrophils, and this really helps the patient because this is a problem of neutropenia. So these are the different therapy which are available for aplastic anemia. Now let me summarize this topic by telling you very important sentences. Please pay attention. Aplastic anemia is a serious disease. It is very difficult to treat, especially in the developing country. Look at the treatment available. Bone marrow transplantation and immunotherapy, both are expensive one. And symptomatic treatment is there, but it doesn't, it doesn't cure the disease. Probably it is just extend the lifespan of the patient. And there are lots of problems associated with blood transfusion itself, like iron overload. There is a chance of introduction of infection in the patient. Okay, the chances of allergic reactions and all those things. So aplastic anemia has to be diagnosed in time, and if possible, we need to counsel the parents of that child for the curative treatment and go for that as soon as possible.